The Subcommittee on Regulatory Reform, Commercial and Antitrust Law will come to order without objection. The chair is authorized to declare recess of the committee at any time. We welcome everyone to today's oversight hearing on the state of competition in the healthcare marketplace. The Patient Protection and Affordable Care Act impacts on competition. I'm going to recognize myself now for an opening statement. Today's hearing marks the beginning of a series of hearings on competition in the healthcare marketplace. First hearing will undertake a broad examination of competition within the hospital, insurance, and physician marketplaces. Additionally, we will also focus on the impact that the Patient Protection and Affordable Care Act, or Obamacare, has had on competition within each of these sectors. There is no doubt that there has been significant movement in each of the hospital, insurer, and physician markets since the enactment of Obamacare. Hospital mergers nearly doubled between 2009 and 2013, the period surrounding the congressional debate of Obamacare and immediately after its enactment. 4 of the 5 largest for-profit health insurance companies recently announced their intent to merge, which will be the subject of a separate subcommittee hearing in the coming weeks. Additionally, reports of physician practices either merging or being purchased by hospitals has increased in recent years. On top of all this activity, we are spending more on health care than ever before, and that number is only expected to grow. I trust that competition will put pressure on market actors to deliver a quality product at a reasonable price. I have infinitely more confidence in the judgment of a competitive marketplace over the judgment of government. Obamacare is another government experiment of attempting to replace the will of the market with its own, an experiment that, in my view, has gone horribly wrong. As chairman of the subcommittee overseeing our antitrust laws and competition, I believe we have a duty to ensure that the laws Congress pass are encouraging competition and that the antitrust laws are being enforced effectively. Today's hearing will help inform Congress of the status of competition in the predominant health care sectors, as well as add to the record of Obamacare's impact on the state of competition in each of these sectors. I look forward to hearing from our witnesses, and I yield back the balance of my time. And I now recognize the ranking member of the Subcommittee on Regulatory Reform, Commercial and Antitrust Law, Mr. Hank Johnson of Georgia, for his opening statement.
Thank you, Mr. Chairman. Today's hearing is the first in a series of hearings that will examine the state of competition in the healthcare marketplace. It is also the third hearing that this committee has held on this topic in as many years. But much has changed since our last hearing in September of 2013. Since the first open enrollment period began in October 2013, the Affordable Care Act has already expanded coverage, savings, and protections for millions of American consumers. Since provisions of the Affordable Care Act have taken effect, the law has resulted in the coverage of 16.4 million uninsured people, dropping the uninsured rate by 35%, the lowest in 50 years, and lowering the overall cost of health care for both insured Americans and health care providers. It saved 9.4 million seniors more than $15 billion on prescription drugs, or about $1,598 for every beneficiary, and it has dramatically slowed the cost of health care spending to the benefit of taxpayers and the entire health care system. The Department of Health and Human Services likewise reported in July that the law has slowed the cost of health care premiums as new competitors enter local markets and price competitions intensifies. The Congressional Budget Office also reported that these lower premium costs have lowered previous cost estimates for the Affordable Care Act by about $142 billion, or 11%, while the Washington Post reports that, quote, the cost of the law has been falling for several years now that analysts are beginning to assess the evidence of the law's impact from its first full year of implementation, end quote. There is also ample evidence that the Affordable Care Act is a reaction to, not cause of, consolidation in the healthcare marketplace. A unifying bipartisan theme of our hearings on this topic is that waves of consolidation among healthcare providers and insurers occurred long before the Affordable Care Act. Whether due to lax antitrust enforcement or bad policy, many local markets are highly consolidated before the enactment of the Affordable Care Act in 2010. According to the Department of Health and Human Services report on competition in health insurance marketplaces, competition has intensified across the country as the number of health insurance issuers have increased in most counties. As I have already noted, this increased competition has had the effect of reducing premium growth through an influx of new plans and increased pressure for incumbent insurance issuers to moderate the cost of premiums. Preserving and promoting this competition is critical, and I encourage the antitrust enforcement agencies to do so at every opportunity. In closing, it's clear that now that we put it to work, the Affordable Care Act is saving lives and money rather than demonizing the administration and the law that has done so much for so many. We would be ensuring that the progress we've made in such a short time is not jeopardized by anti-competitive behavior or consolidation. With that in mind, and notwithstanding the consistently partisan nature of discussions concerning health care and the Affordable Care Act, I thank the Chair for calling this hearing, and I look forward to future hearings on this subject. Few topics directly affect the lives of American consumers as ensuring that health care markets are delivering the best and most health care choices in every county in America. And with that, I will yield back. But let me say before I yield back, I'd like to offer into the record without objection the statement of Ranking Member John Conyers.
So ordered and without objection.
I yield back.
The Chair recognizes the Chairman of the full Judiciary Committee, Mr. Bob Goodlatte of Virginia, for his opening statement.
Thank you, Mr. Chairman. Before we begin today's hearing, which marks the beginning of a series of hearings on competition in the healthcare marketplace, I think it would be helpful to clarify 2 points of overriding concern. First, healthcare is not provided in a true free market and has not been provided in a free market since at least the onset of major government intervention in the market through Medicare and Medicaid. Second, healthcare as a service is unique in that nearly every person in America will require some medical treatment over the course of their lives. Health insurance is not like fire insurance or car insurance, where there is a hope that one will never have to use it. Medical costs inevitably occur, and hopefully insurance or some funds set aside for these costs will be used when the time comes. In the face of these facts, that the healthcare market is not a fully free market and that Americans have no choice but to participate in the market, it is essential that we preserve as much competition and freedom in the overall healthcare marketplace as we can. We should strive to enact laws that foster competition so that prices are checked, patients have choices, and the premium quality of American healthcare can be maintained. Otherwise, costs will go up, choices will narrow, and quality will be diminished. That is simply the laws of economics at work. In 2010, President Obama signed into law the Patient Protection and Affordable Care Act, which I believe is antithetical to competition. Rather than promoting free markets, Obamacare put in place a regulatory structure that stifled competition and instituted incentives for increased market consolidation. Since the enactment of Obamacare, I have been sounding the alarm bells. The Judiciary Committee held hearings on Obamacare and competition in each of the last 2 congressional sessions. I am pleased that the committee meets again to continue to sound the siren and supplement the growing record of Obamacare's anti-competitive results. One of the principal tenets of economics is that competition can lead to lower prices, enhanced product variety, greater innovation, and downward pressure on costs. When markets consolidate, there exists the potential for reduced competition, resulting in the contraction of the related benefits. Of course, consolidation does not always lead to a reduction in competition. Market efficiencies can be obtained, and the expansion of successful products can be achieved through more rapidly through transactions. However, when non-market and government forces compel consolidation, those underlying forces and their effects should be closely examined. Accordingly, it is vitally important that antitrust laws are properly and consistently enforced to prevent anti-competitive consolidation and conduct, and that laws that promote these activities are subject to strict and ongoing scrutiny. Continuous and vigilant oversight, such as today's hearing, will help to ensure that healthcare markets operate as freely and competitively as possible in order to provide consumers with premier and affordable health care. I look forward to the testimony of our witnesses on the state of competition in the predominant healthcare markets, and thank you, Mr. Chairman. I yield back.
Thank you, Chairman Goodlatte. Without objection, other members' opening statements will be made part of the record. Now I'll begin by swearing in the witnesses in. Would you please stand and raise your right hand, please? Do you swear that the testimony you are about to give before the committee is the truth, the whole truth, and nothing but the truth, so help you God? Let the record reflect that all the witnesses have answered in the affirmative. Please be seated. We have a distinguished group of witnesses here today that I think are going to contribute a great deal to some of the questions that we would like to have answered. I'm going to begin with Professor Thomas L. Greeny. Is a Chester A. Myers Professor of Law and co-director of the Center for Health Law Studies at the St. Louis University School of Law. Professor Greeny also is the author of Health Law, one of the leading healthcare case books, as well as numerous articles in the intersection of antitrust and health law that have been published in, among other places, the New England Journal of Medicine, the Antitrust Law Journal, the Journal of the American Medical Association, and the Yale Journal of Health, Law, and Policy. Prior to joining the St. Louis University School of Law, Professor Greeny served as the Assistant Chief in the Antitrust Division of the Department of Justice. Mr. Greeny received his BA magna cum laude from Wesleyan University and his JD from Harvard Law School. Welcome, Professor. Mr. Richard Pollack recently became the 11th President and CEO of the American Hospital Association, known as AHA, on September 1st, 2015. Mr. Pollack has been with the AHA for over 32 years, recently serving as the institution's Executive Vice President for Advocacy and the Public Policy, where he was responsible for the development, implementation, and management of the association's advocacy, representation, and public affairs activities. Mr. Pollack started his professional career here on Capitol Hill, serving as a legislative assistant to former Congressman Dave Obey. Mr. Pollack earned his bachelor's degree in political science and communications from the State University of New York's College at Cortland and his master's degree in public administration from American University. Welcome, Mr. Pollack. Dr. Barbara McEnany was reelected on June 2014 to the American Medical Association AMA Board of Trustees. Dr. McEnany is a board-certified medical oncologist and hematologist from Albuquerque, New Mexico, and has served in numerous leadership roles at the AMA. Additionally, Dr. McEnany was appointed by Health and Human Services Secretary Tommy Thompson to the Practicing Physicians Advisory Council from 2002 to 2006. Dr. McEnany graduated magna cum laude from the University of Minnesota and with honors from the University of Iowa College of Medicine. Doctor, welcome. Mr. Dan Durham is the Executive Vice President of Strategic Initiatives at America's Health Insurance Plan, known as AHIP. Mr. Durham has over 30 years of leadership experience with major policy and regulatory issues, primarily in the healthcare field. In addition to holding senior positions within AHIP, Mr. Durham served in high-level policy positions in the federal government, at the United States Department of Health and Human Services, the Social Security Administration, and the Office of Management and Budget. Mr. Durham received his BA from the University of Notre Dame and his master's degree from Duke University. Mr. Durham, welcome to you also. Dr. Scott Gottlieb is a recent fellow at American Enterprise Institute and a practicing physician. Dr. Gottlieb has served in various capacities at the Food and Drug Administration, including as Senior Advisor for Medical Technology, Director of Medical Policy Development, and most recently, Deputy Commissioner for Medical and Scientific Affairs, in addition to serving as a Senior Policy Advisor at the Centers for Medicare and Medicaid Services. Dr. Gottlieb is also a prolific writer on healthcare issues and has been published in leading medical journals and other well-respected periodicals. Dr. Gottlieb received his BA in economics from Wesley University and his MD from Mount Sinai School of Medicine of New York University. Welcome, Doctor. Each of the witnesses' written statements will be entered into the record in its entirety. And I ask each of the witnesses to summarize his or her testimony in 5 minutes or less. And to help you with the timing, you see the lights in front of you. The lights will switch from green to yellow, indicating that you have 1 minute to conclude your testimony. And when the light turns red, it indicates that the witnesses have 5 minutes, that the witnesses' 5 minutes have expired. And I do this, and I know that probably some of you are going to do it. We're so intent on saying what we want to say or reading our statements that we pay no attention to those lights. And I will very politely just sort of raise the gavel to get your attention to ask you to please summarize. So, thank you. So with that, Dr. Greeny, would you like to make your opening statement? Would you put your microphone on, sir?
Thank you very much. Good luck, Chairman Marino and Ranking Member.
Could you pull it a little closer to you? Because off to the side.
Ranking Member Johnson. I appreciate this opportunity to testify again before this committee. Let me summarize my testimony with 4 key points. First of all, the Affordable Care Act both depends upon and promotes competition in healthcare markets. And secondly, while there's no doubt that excessive concentration undermines the competitive policies of the ACA, it's entirely erroneous to claim that the ACA is somehow responsible for this consolidation. Mergers to monopoly and oligopoly are efforts to avoid or frustrate the act. Third, the recently announced health insurance mergers threaten competition in a variety of product markets and merit careful scrutiny. The only point I'm going to make there is that you should not be taken in by the argument that consumers are somehow better off having big insurers confront big hospitals. I call that the sumo wrestler theory. And finally, my last point is that if state and federal legislators are concerned about competitiveness of healthcare markets, as they should be, it's finally time to take a hard look at the real problems that beset the healthcare market. Outdated regulations, anti-competitive practices that can be corrected by pro-competitive legislation, and payment incentives that wrongly encourage consolidation. Those are your real culprits, not the ACA. Okay, let me begin with my first point. The ACA does not regulate prices. It relies heavily on private sector competition between providers and payers, and rivalry within each of those markets. Why do we need government regulation to help competition? Well, let's remember what that putative market, as we like to call it, looked like before health reform. There was a dysfunctional market for individuals and small groups. We had a non-system of service delivery, as hospitals and physicians each operated in their own silos. And we had payment systems that rewarded volume and not outcomes. What has the ACA done to improve market competition? My written testimony goes into a variety of areas, but most importantly, it put in place efficient markets for shopping and bargaining in the individual and small group market. Very importantly, the exchanges set up mechanisms to shop and compete. And remember that the ACA also put in rules that made insurance products now comparable, understandable, and assure basic levels of coverage. These are economics 101 conditions for better competition. What do we have as a result? Well-functioning exchange markets that have enabled over 10 million people to shop for and find products. The doomsday predictions about the exchanges: risk selection would destroy the exchanges, policies would be unaffordable, employer-sponsored markets would crumble, proved to be wrong, and wrong. As to the commercial market, the ACA also had important salutary effects. First and foremost, it forbid insurers to engage in medical underwriting, going after pre-existing conditions. That sent a message to the insurance market that's very important. I want to channel Bill Belichick here. It said, do your job to insurers. Develop health plans that control costs and improve quality rather than chase risks. And widely overlooked is what the ACA did with Medicare reform, because what it is still undergoing. Medicare payment reform, emphasizing now value-based purchasing, ACOs, and lots of other things, shift delivery in a very important way. And we know that private commercial markets follow what Medicare does. So is everything copacetic? No. Unfortunately, concentration is a big problem, but we know much of that, a little history is in order, much of the most problematic concentration preceded the ACA. The good news is that the DOJ and FTC are on the job and have won a series of important victories that should send a clear message about future consolidation. I'll just mention very briefly my point on insurance sector consolidation, since my time is running short. The insurance market consolidation is problematic. It's going to take an in-depth inquiry by the Department of Justice. But the concept, and it's a fallacious one in my view, is the idea that somehow we're better off where we pit dominant insurers against dominant hospitals. That's unsupported by the economic evidence, and both in theory and in practice. There are lots of antitrust cases where we've seen lots of large insurers and hospitals confronting each other, and they find a way to either conspire with each other, either hurting rivals or simply splitting the spoils of their market power. Sometimes we find out that the sumo wrestlers would rather shake hands than compete. I've listed a long list of ideas for a pro-competitive agenda, including things that would help deconcentrate markets. There are a number of steps that can be taken. I commend Dr. McEnany's testimony, which I think gives many of the ideas which I support. So I think those are the steps that would promote competition and advance the goals of this committee.
Thank you, Professor. Mr. Pollack.
Chairman Marino, Ranking Member Johnson, and distinguished members of the committee, on behalf of our nation's hospitals, I appreciate your inviting me to be here today. The healthcare landscape is rapidly changing, and hospitals are helping to lead the way forward. They are focusing on improving the patient care experience, enhancing quality, and lowering the cost of patient care. Many of the market forces reshaping healthcare were in place long before the passage of the Affordable Care Act, but the ACA has accelerated that pace of change. A major part of that change is the realignment in the hospital field that I'd like to discuss this morning. The emphasis on wellness or population health has encouraged collaboration among providers along with the development of coordinated care models. These new models are often value, not volume, or cost-based, which means that providers are at financial risk if they don't achieve specified quality and cost goals. The Department of Health and Human Services has launched a number of these programs, and by 2018, it expects to move half of all Medicare payments to alternative models of reimbursement that reward value. The department has also recognized that achieving these goals would require hospitals to make fundamental changes in their day-to-day operations that improve quality and reduce the cost of care. For hospitals and health systems, realigning and transforming care means closely working with other providers to make sure that patients and communities have convenient access to care. That means coordinating with doctors and other caregivers to deliver better patient-centered care. It means hospitals are aligning with other hospitals to unify patient information, better coordinate transitions, and follow-up care and share financial risk, among other improvements. And it means partnering to keep the doors of certain financially failing hospitals open so that patients won't lose access to the medical care they and their community rely on. For example, a health system in Ohio acquired a small community hospital in bankruptcy. It saved 250 community jobs and actually expanded access to care in that rural area. And many small, standalone, and rural hospitals are particularly in need of partners. Just the cost of acquiring and maintaining electronic medical records, which can be as much as $50 million for a mid-sized hospital, can tip the financial balance of these organizations. Outdated regulatory barriers continue to constrain the pace of innovation. And despite repeated calls for the federal agencies to modernize these regulations, to date, only one has been changed. For example, we've repeatedly asked the Federal Trade Commission, which oversees transactions in the hospital field, for guidance on constructing clinical integration arrangements that could, in some instances, take the place of mergers. However, we have not received this guidance. Now, despite these challenges, the results of hospital realignment are promising. It's even impressive. The author of a recent study in the Journal of the American Medical Association used the term jaw-dropping to describe the results, which found hospitalizations and costs going down for patients. He observed that there has been tremendous focus on making sure that our hospitals are safer and that treatments are more timely and more effective. Moreover, he acknowledged that the savings per patient did not come at the expense of quality. And let me highlight just one other fact, and that's that hospital price growth is at historically low levels, less than 1% in 2015. Now, while I understand that this hearing is not focused on the recently announced health insurance acquisitions, I'd just like to briefly touch on that point. We have serious concerns about two potential acquisitions and believe they merit the greatest scrutiny from both the Department of Justice's Antitrust Division as well as Congress. Anthem's proposed acquisition of Cigna and Aetna's proposed acquisition of Humana would eliminate two of the largest national health insurance companies, leaving just three dominant national providers of health insurance. That would leave consumers with fewer and no doubt more expensive options for coverage, and it would diminish the insurer's willingness to be innovative partners with providers and consumers to transform care. In conclusion, I just want to say that Americans' hospitals are woven into the fabric of our communities. Hospitals care for patients when they are sick, and we work to keep communities healthy. We have tried to lead the way and will continue to try to lead the way to reshape the system, to improve quality, to improve efficiency, and to make health care more affordable for patients and families. And we certainly look forward to working with the committee on making sure that consumers have access to high-quality, affordable care in their communities. Thank you.
Thank you, Mr. Pollack. Dr. McEnany.
Thank you. Good morning. I am Dr. Barbara McEnany. I'm a cancer doctor practicing in New Mexico, and I am immediate past chair of the American Medical Association. Thank you for inviting us to participate in this oversight hearing on competition in the healthcare marketplace. Physicians want to participate in a healthcare delivery system that allows us to deliver high quality and efficient care to our patients. We believe that competition between and among healthcare providers, facilities, and insurers is an excellent prescription for achieving that goal. The Affordable Care Act, which includes provisions that are designed to stimulate competitive forces in the segments of the healthcare market, is a disruptive force whose impact is still being revealed. New payment and delivery models focusing on quality and efficiency can foster competition by encouraging innovation. Physician leadership in these new models is critical, both to protecting patients' interests and driving down costs. Indeed, preserving the ability of physicians to participate in alternative payment models, including small or specialty or rural practices, is essential because it ensures patient choice, preserves the doctor-patient relationship, and provides better competition in healthcare markets. Therefore, we recommend reassessing and removing legal barriers that inhibit physician engagement. Specifically, we strongly support the FTC and DOJ efforts to clarify the application of antitrust laws and urge additional guidance to encourage the development of physician-guided innovative delivery models. Currently, broad prohibitions under the federal fraud and abuse laws discourage physicians from adopting innovative incentive programs that could kickstart competition. We therefore urge Congress and the administration to strengthen and expand program integrity exemptions for physicians participating in alternative delivery and payment models. Ultimately, physicians should be able to maintain independent practices and participate in innovative care models. Anti-competitive hospital markets may undermine the incentive of hospitals to compete based on quality, potentially laying the groundwork for suboptimal care. Lifting the ban on new physician-owned hospitals, which have developed an enviable track record on quality and cost, offers one way to inject new competition into hospital markets. Similarly, we believe that competition, not consolidation, is the right prescription for health insurer markets. Competition can lower premiums, enhance patient care, and spur innovative ways to improve quality while lowering costs. Our annual study of commercial health insurance markets shows that 70% are already highly concentrated. We believe that there must be a rigorous review of proposed mergers to determine their effects on competition and their consequences on patient care. In 2010, the Department of Justice found that the proposed Blue Cross merger in Michigan would have resulted in, quote, the ability to control physician reimbursement rates in a manner that could harm the quality of health care delivered to consumers, end quote. The same analysis should be applied to pending mergers. In practice, the concentration of market power among a handful of nationwide insurers impacts physicians' ability to facilitate individualized care. Doctors are left with no recourse to advocate for our patients, and innovation is stifled. Market dominance does not produce patient benefits when physicians are squeezed and networks are narrowed. Patients should be able to select their doctors based on quality and service, and doctors should be freed to get patients what they need and deserve. This is a stark reminder of what is at stake, the health and safety of American patients. We are at a critical decision point on health insurance mergers because once the handful of national payers is further reduced, there is simply no going back. Post-merger remedies are likely to be both ineffective and highly disruptive. Thus, we believe that the time for heightened scrutiny and careful consideration is now, before proposed mergers take effect and result in a fait accompli, wherein patients and physician practices are permanently harmed. Competition plays a major role in enabling patients to access high-quality care they deserve at a reasonable cost. We thank the subcommittee for your continued efforts on this issue, and we look forward to working with you to improve healthcare competition. Thank you.
Thank you, Doctor. Mr. Durham.
Good morning, Subcommittee Chairman Marino, Chairman Goodlett, and Ranking Member Johnson, and members of the subcommittee. I'm Dan Durham, Executive Vice President at America's Health Insurance Plans, and I appreciate this opportunity to testify on issues regarding competition in the healthcare system. A competitive healthcare system is the best way to achieve innovative, high-quality, affordable healthcare. Competition among health plans occurs at the local level, and the diversity of AHIP's membership, which includes local, regional, and national plans, reflects the many choices available to consumers. Innovation in payment and delivery has resulted in a broad range of options available in the marketplace as health plans continually work in collaboration with providers to improve the value of their products for consumers. Our written testimony highlights initiatives that our members have pioneered to promote quality and affordability, as well as consumer tools that promote patient-centered care. Regarding competition in the marketplace, the Department of Health and Human Services reports that an average of 40 plan options are available per county in 2015. That's up from 30 last year. And McKinsey reports a 26% increase in the number of issuers competing in exchanges. Competition within local markets is evolving with a variety of high-value products, from patient-centered medical homes to bundled payments to accountable care models. The range of collaborative products that drive value is vast, and health plans tailor these products to meet the specific needs of local patient populations. Has been reported, there is merger activity in the health insurance industry. While I can't speak to the potential outcomes of these reviews, it's important to understand the broad framework that the antitrust agencies use to evaluate whether a particular transaction is pro-competitive or anti-competitive, and the evolving nature of the market for health coverage. Assessing the impact of proposed mergers should start with a clear understanding that many mergers and acquisitions are beneficial to consumers. They can facilitate new, high-value products and efficiencies that reduce cost. The Department of Justice has indicated, and I quote, "The primary benefit of mergers to the economy is their potential to generate significant efficiencies and thus enhance the merged firm's ability and incentives to compete, which may result in lower prices, improved quality, enhanced service, or new products." The DOJ, along with 50 state attorneys general and insurance commissioners, play an important role in reviewing proposed mergers and determining their potential impacts. This includes a thorough evaluation of a large body of data and other evidence to determine whether a merger would harm consumers by adversely impacting competition in specific products and specific geographic areas. Notably, there is no single market for health coverage. Health plans negotiate with providers in local markets and offer particular types of products that differ widely from one another. The agencies also consider the nature of the market itself and whether it's undergoing changes that are relevant to their analysis. For example, in the highly regulated nature of health insurance markets, it's relevant to do an analysis of the potential competitive effects of transactions. This highly regulated market we face distinguishes health insurance from other less regulated markets. The bottom line is that consolidation should be looked at on a case-by-case basis, and that it is problematic only when a transaction leads to anti-competitive effects, such as an increase in costs resulting from harmful consolidation in provider markets. There is substantial evidence in peer-reviewed research that shows a significant share of healthcare cost increases are driven by dominant providers charging higher prices. A Robert Wood Johnson Foundation study found that increases in hospital market concentration led to increases in the price of hospital care, and that when hospitals merge in already concentrated markets, the price increase can be dramatic, often exceeding 20%. This study further cautions that physician-hospital consolidation has not led to either improved quality or reduced costs. Other studies that we've detailed in our written testimony show that anti-competitive consolidation in provider markets is resulting in higher healthcare costs for consumers and employers and government programs. Thank you again for this opportunity to testify. AHIP and our members look forward to continuing to work with the subcommittee and other stakeholders to improve patient access to high-quality, affordable health care.
Thank you, Mr. Durham. Dr. Gottlieb.
Thank you, Mr. Chairman and Mr. Ranking Member, for the opportunity to testify. My name is Scott Gottlieb. I'm a physician and resident fellow at the American Enterprise Institute. The healthcare sector is undergoing a secular consolidation as payers and providers assume a historic level of mergers and acquisitions. These trends were underway prior to implementation of the Affordable Care Act, but there is no question that the ACA hastened them. The consolidation of physicians at the local level should be of particular concern. In the end, most healthcare is local. Once an institution has monopolized the providers in its market, it renders market-based reforms hard to achieve and reduces the ability of competition to be used as a tool for improving quality and reducing costs. More importantly, the new arrangements that are being forged, where doctors become part of large delivery systems, usually with a hospital at its hub, reduces productivity. Compelling economies of scale are not apparent in the physician practice marketplace. This has been borne out by many studies that examine the question, some of which I review in my written statement for this hearing. There's a lot of evidence that as doctors transition to becoming salaried employees of hospitals and health systems, their individual productivity, in terms of metrics such as volume and intensity of care delivered, also generally declines. Looking at this in view of our broader fiscal challenges when it comes to healthcare, the only way that we're going to solve some of our challenges facing entitlement programs like Medicare is to get more healthcare for every dollar of GDP that we spend on it. To these ends, the last thing we ought to be doing is adopting structures that reduce productivity. I know there will be some discussion today of new technology, and particularly drugs, as factors driving increases in the cost of medical care, and I want to just comment briefly on that. However one interprets the data on drug costs, it's widely agreed that many new technologies improve productivity, by improving outcomes or obviating costly alternatives. Take oncology care. Although very costly, total spending on oncology care as a percentage of our $2.7 trillion national health care budget has been constant over the last 20 years at just less than 5% of total health care spending. It comes out to about 0.8% of GDP. But the mix of expenditure has changed dramatically over time. Far less money is being spent on services like hospitalizations and far more on outpatient medicines. Cancer treatments that used to make patients very sick and require costly hospitalizations have been replaced with targeted drugs that can allow patients to be treated at home. So the proportion of spending on inpatient care admissions fell from 64% of total cancer spending in 1987 to 27% by 2005, according to studies. Here's what happened. Transferring cancer care to the outpatient setting produced substantial savings. It's cheaper to deliver care outside the hospital. This is how technology improves productivity and lower costs. Which brings me back to the consolidation underway in the market for healthcare services. This consolidation not only reduces productivity and in turn increases costs, it also reduces patient access. This is especially troubling when it comes to rural markets where there's a lower density of doctors and patients can find it harder to get care at a site near their homes. It's important to remember that the scope of the consolidation that we're seeing in healthcare is not a response to market factors. Rather, it's a deliberate function of policy choices. The ACA envisions doctors practicing in large integrated health systems, often with a hospital at its hub. The idea is that these newly consolidated entities will be big enough to take capitated risk and invest in the kinds of technologies that, it's believed, will lead to better coordination of medical care. The ACA's mix of policies seeks to hasten these outcomes. The relationships that doctor practices are forging with their acquiring entities are far stickier than past arrangements. Moreover, for doctors, the opportunity to unwind these business engagements and go back to their old configurations are much more narrow. The economics behind these arrangements also raises some more fundamental questions. For one thing, these constructs were in part a response to criticism of the fee-for-service approach to payment, which is widely presumed to give doctors a financial incentive to prescribe more care. As the analysis commonly goes, under the fee-for-service arrangement, doctors are paid more when they do more things and not necessarily when they improve outcomes. But in reaction to these concerns, have we merely traded one flawed set of financial incentives for another? After all, if the financial incentives work in one direction, they have to work in the opposite direction. If doctors will prescribe too much care when they're paid to do more, as critics of the fee-for-service medicine system maintain, won't these same inducements work in reverse? Won't doctors prescribe too little care when they're paid to do less? This also raises another key question, and this one's clinical. Are patients better off on the margin when they're prescribed a little more care than they need or a little less? The body of literature doesn't fully resolve this question. Since all healthcare is local and the lack of competition will soon make it much harder to implement market-based reforms in healthcare, the resulting monopolies will make more regulation the most obvious solution to the inevitable cost and quality problems. To change these outcomes, I believe that Congress needs to reform the ACA to remove the pervasive biases in the ACA that favor health system ownership of medical practices. At a time when the urge to merge doctors into health systems and turn physicians into salaried roles, there's a private market counter-effort to create new models that have physicians practicing in smaller units. Many aspects of medical practice are not responsive to scale, and where scale does help, many of the characteristics of healthcare that benefit from integration can be achieved without consolidation, but by better use of technology. A legislative proposal to improve healthcare quality and manage its costs would support local competition between providers and choice for patients. We need to improve productivity and preserve entrepreneurship, autonomy, and local competition that have long been the hallmarks of American medical progress. Thank you.
Thank you, Dr. Gottlieb. Members of the dais will now begin their 5 minutes of questioning, and I recognize myself for my 5 minutes. Mr. Pollack, I would like to begin with you, sir. There have been a number of reports of hospitals purchasing physician practices. In some cases, patients enter the same building and see the same doctor after the purchase, but the Medicare reimbursement rate for the service is significantly higher. In some instances, Obamacare increased these pricing disparities. Are Medicare reimbursement rates driving purchases of physician practices, and do you think that will impact Medicare's solvency?
Well, I think, Mr. Chairman, there are two issues here. One is the issue of physicians wanting to be part of teams and wanting to be part of group practices that deliver care in a coordinated way. And very often they are being part of the hospital entity. And that's certainly a trend that we're seeing. When physicians do become part of the hospital entity and they deliver services within the hospital entity, there are requirements that have to be met that they are part of that facility, as opposed to providing service in their own office or in a different site. Hospital costs for those physicians are legitimately higher, and the Medicare rate does in fact reflect a higher amount. And that is legitimate in our view because the regulatory requirements for practice in that setting are very different than what the requirements are in a physician office or an ambulatory care center. The patients we take care of in that setting is anyone that walks through the door, Medicare, Medicaid. We are open 24 hours, 7 days a week. The patients that are taken care of in those hospital-based physician clinics tend to be sicker, and we have studies that we're happy to submit for the record that shows they're poorer and more economically challenged. They suffer from a more difficult set of circumstances. So it is, in fact, more expensive to take care of patients in those types of settings.
Right. Thank you. Dr. McInerney, would you like to respond to that, please? To my question.
Yes, thank you very much, Mr. Chairman. I take care of cancer patients in a very poor community in New Mexico, which ranks at the lowest for income. And while the American Medical Association supports the right of physicians to choose employment, we focus on the word choose. We don't believe that competition should force physicians to select employment over self-employment or other options. I do disagree with the statement that we are unable to take care of sicker patients in the outpatient arena. In our practice, if I sold to the hospital tomorrow and I saw the same patient and did the same services, you are absolutely correct. I would be reimbursed at a higher level if I were hospital-based than physician fee schedule. But we do take care of very ill patients, and we manage to keep them in the outpatient arena. The regulatory burden that physicians have is one of the impediments to physician practices. The ability to be able to comply with all the regulatory requirements are one of the barriers that have driven younger physicians in particular to wanting to join hospitals in hopes that someone else will take care of all that and just let me see my patients.
Great. Thank you. Dr. Gottlieb, I have a specific question for you. In your testimony, you stated that there has been a net loss of insurers since the enactment of Obamacare. You also discussed co-op insurance plans that have been subsidized under Obamacare. Can you discuss the success rate of the co-ops insurance plans and how the declining number of insurers will affect competition in the insurer marketplace? And you have about 56 seconds.
Well, I'm referring mostly to the commercial marketplace. There's been no new net commercial insurance company formation since the enactment of Obamacare, actually since 2008. So whatever new plans we've seen, new carriers enter the market, we've seen offsetting losses, and actually we've seen a loss of new carriers. We've seen new plans enter the market, but they've all been existing carriers that have decided to offer plans on the exchanges. They're not new carriers. So I don't think that's very robust competition. It's an indication that investors aren't allocating capital to start new health plans. I think because of the regulatory impediments and the high costs of getting into the market. As far as the co-ops and the provider-sponsored plans, particularly the hospital-sponsored plans, I think the administration envisions that picking up the slack and providing competition. But the co-ops are all, I think, almost all underwater, and one has already declared bankruptcy. And I'm not very optimistic that a lot of the provider-sponsored health plans are going to survive. We've done this in the past, and what's been demonstrated that hospitals don't manage risk well. There's a reason why insurance companies exist.
Thank you. My time has expired. The chair recognizes the ranking member, Mr. Johnson.
Thank you, Mr. Chairman. Dr. Gottlieb, do you disagree with all of the studies which have proven that the cost of health care insurance premiums, the increases in the cost of insurance premiums has gone down since the onset of the Affordable Care Act?
What I see is that...
Do you agree or disagree that.
Well, I disagree with the premise because what I'm seeing is that costs are being shifted to consumers. So the cost of providing coverage for employers, which is what the administration often cites, has in fact been
My question has
grown
to
less
do with-
quickly than in the past.
My question has to do with the premium growth, the cost of premiums, the growth in the cost.
Right.
of
So the cost that would
not shifting of cost to consumers. I'm just talking about the cost of health care premiums and the rise in the cost of health care premiums.
right.
Do you
So-
agree that the price increases have moderated since the passage of the Affordable Care Act?
I disagree because the
Okay,
cost to
well, thank you.
consumers has gone up.
All right, thank you. You just refused to answer that question. Well, let me ask you this. Do you,
The witness, I'm going to give the witness 30 seconds to respond to that.
no.
Yes, I'm going to give the
From
witness
whose
30
time?
seconds.
From whose time, Mr.
From
Chairman?
your time. You have to let
No,
the
no, no,
witness,
no, no, no,
you
no,
must
I
let the
do
witness
not.
answer the question.
Mr.
Sir,
Chairman, the
Dr.
witness
Gottlieb,
did
please,
not answer
please
the
respond
question.
if you'd like to respond.
Well,
I got a
premium-
parliamentary order, parliamentary inquiry, Mr. Chairman.
Yes.
Who controls the time during my questioning of my witnesses?
I do. Mr. Dr.
All right, well,
Gottlieb,
I'm
you
going to
answer the
take
question.
exception. I'm going to take exception. I'm
Exception,
going to,
exception noted.
Yeah, in fact,
Dr. Gottlieb,
I'm just
you
going to.
you may go ahead and answer the question. No, you have to give the witness.
No, I
You
do
have to
not.
give the witness an opportunity to answer the
Mr.
question.
Chairman, when I ask a question and the witness refuses to answer the question, as
You
this
didn't give
witness
him an
has done,
opportunity to answer the question. You
witness
kept cutting him off.
refused to answer the question, and it's my prerogative, Mr. Chairman, as the questioner.
You still have
to-
your time. You still have your
Yeah,
time.
my time is running because I'm responding to your interruption of my questions.
You continue to ask your questions, and then I will give him
Oh,
30 seconds when you're
Mr.
complete.
Chairman, you started at 4 minutes and 20 seconds. I had 4 minutes and 20
Go ahead.
seconds when you interrupted me to try to
Go ahead.
give
You
this
ha- you
witness
have
an
the extra-
opportunity to
you have the
answer
extra
my
time.
question in the way that he wanted to answer.
You have the extra time. Go ahead and begin your questions.
All right. Okay. Now, Dr. Gottlieb, I asked you a question. Do you agree or disagree with the studies that have shown that the rise in premium costs has been moderated since the passage of the Affordable Care Act? And you went into a discussion about shifting of costs to consumers. That's not my question. I'll give you one last chance to answer my question, and I think you understand my question.
So
Do you agree or disagree with those studies?
I disagree with those studies
All right,
because I
thank
think
you,
they're
sir.
flawed.
Thank you. All right. Now, Dr. Gottlieb, do you agree that Congress should repeal the McCarran-Ferguson Act's antitrust exemptions for insurance companies?
No, I
Look-
do not.
All right, thank you. Dr. McEnany, is that I hope I pronounced that correctly. In a speech in June of 2015, FTC Commissioner Julie Brill stated that while the antitrust agencies are watchful of anti-competitive behavior, not one accountable care organization has been challenged for anti-competitive conduct by the antitrust agencies. What is your response to this approach to provider collaborations in the healthcare marketplace?
I think the antitrust laws are very confusing to people with or without an affordable care organization to try to create an organization that allows us to collaborate as physicians, take economic and risk together, and to do clinical integration. And I can't speak as a physician, since I'm not a lawyer, to what the FTC and DOJ are doing with that, but we feel that if we could release some of those barriers and make those laws much more clear so that physicians could understand them and stay within the confines of the law but still be able to collaborate together, we wouldn't have to become employees or consolidate the industry in order to create a lot of new mechanisms that could deliver better care at a lower cost.
Thank you. In your written testimony, you argue that Medicare and Medicare Advantage are distinct product markets, why is Medicare not an adequate substitute for Medicare Advantage? And what effect would consolidation in the Medicare Advantage market have on physicians and seniors?
Thank you, sir, for that question. The AMA has found that very few patients will switch back and forth from Medicare Advantage programs to plain fee-for-service Medicare, in part because of the concerns of being able to pay the 20% copay with fee-for-service Medicare. The Medicare Advantage programs have been given extra money to be able to provide better benefits, and patients respond to that. What we find is that when those patients consolidate into fewer and fewer Medicare Advantage plans, that if the benefits are not what the patient wants, if their physician, for example, is not on the panel of that Medicare Advantage program, that they have a distinct disadvantage in being able to get care, and they're often forced to pick between competing. Their primary care doctor is on one and their specialist is on another, and they need both of us. So we look at the managed care Medicare Advantage market as being distinct from fee-for-service Medicare for those reasons.
All right, thank you. Mr. Greeny, in their testimony, both Mr. Pollack and Dr. Gottlieb observed that consolidation in the healthcare marketplace was hastened by the ACA. What's your response to that?
I think that's a bit misleading. Surely the Affordable Care Act encourages providers to get together, to consolidate, to form efficient delivery systems. And that is certainly true. But nothing in the ACA encourages consolidation to monopolies and oligopolies. And in fact, just to give you an example, your doctor probably tells you a glass of wine with dinner every night is probably a good thing, but he would counsel against 2 bottles of wine. And I think that's what we're talking about here. We're talking about consolidation that's excessive. And as I've said in my testimony, the Affordable Care Act is premised on having competitive units at the delivery level and at the insurance level, so that the ACA relied on competition and relies on healthy enforcement of the antitrust laws. And if you look to the string of victories the FTC has achieved, both in hospital markets and in challenging physician mergers, it's doing its job. So to that extent, blaming the ACA for consolidation is misleading, because I don't think you'd be hard-pressed to find a healthcare economist or policy person who thought what was needed was anything but the fragmentation that we've had heretofore.
Thank you, and I yield back.
The chair recognizes the chairman of the full committee, Congressman Goodlatte.
Thank you, Mr. Chairman. Dr. Gottlieb, I think you wanted to explain your answer with regard to the trends with regard to insurance premiums, and I think you should be afforded that opportunity, so I'll give that to you now.
Thank you, Congressman. What we've seen in the market, and what the administration often talks about, is the cost of coverage, of providing coverage for employers to their employees, and premium growth. And it's true that premium growth, at least in the recent years, has moderated, although we're seeing it accelerate quite dramatically. But what's happened is we've seen a very dramatic shift of cost to consumers. We've seen the advent of very narrow network plans, closed drug formularies, closed networks, exclusive provider organizations, and all of that has served to shift costs onto consumers. And I think that that's a big
Things that aren't
component.
covered by the insurance, in other words.
Exactly.
So the opposite of what was purported to be the benefit of Obamacare.
Well, closed drug formularies in particular is a real new phenomenon in the market. The only place where we had seen closed drug formularies prior to implementation of the Affordable Care Act was in Medicare Advantage, but Medicare Advantage had the protected classes, which made sure that the formularies were robust. What's happening in the Affordable Care Act and the exchange-based plans is there's closed drug formularies where if the drug isn't on the plan's formulary, you're completely out of pocket, and what you spend doesn't count against your deductible.
I need to take my time for other things. So what you're saying is that whether or not insurance premiums are moderating, that doesn't necessarily mean that the overall cost to the consumer and overall cost to society,
Exactly.
overall cost to taxpayers has moderated.
It's gone up quite a bit to the consumer.
Great, thank you. Dr. McEnany, I may come back to Dr. Gottlieb if I have time, but he said that health system ownership of medical practices is an undesirable trend. You said that you wanted to make sure that they had choice, and in a moment I'll go to Mr. Pollack and give him an opportunity to respond as well. But one of the things that I see and one of the things I hear from my physicians is that they're actually in competition with the employees who are at the hospital, and it is very difficult to compete with them when there are such disparate reimbursement rates that take place in the hospital compared to what the physician may get in their private practice. What's your observation about that?
Well, Mr. Chairman, I think you summarized it very well, that it is very difficult for individual physicians to be able to compete with hospital-based physicians because they have the leverage that we as individuals lack to be able to negotiate with insurance companies. We find that the regulatory burden is still there in the independent market, and that hospitals are able to purchase a lot of the same supplies and everything else that we need to purchase at a lower price or a subsidized price.
Mr. Pollack, I take your point regarding the cost of operating a hospital, but I also am concerned that if we're trying to promote competition and there's only one hospital in a community and that hospital has people providing a services in this area, how do the private practitioners successfully compete with the hospital practitioners, if you will, in that kind of marketplace? And what are the trends there? I see a lot of consolidation. I think Dr. McEnany said it already at 70% perhaps of physicians going into work in hospitals. Where do you get the competition if they all go into the hospital and nobody's out there providing that competition?
I think some of the competition is among hospital systems. And I think what we have to remember here is that we have a new way of paying for a lot of care in terms of different mechanisms that require payment for taking care of.
What if there's only one hospital in the community?
By the way, you made an eloquent point at the very beginning, Mr. Chairman, about how healthcare is a unique kind of market.
I agree with that.
There are 13.
But I'm not going to let you off the hook on that. We still got to find ways to compete.
But your point's very well taken. There are 1,300 critical access hospitals in this country in which there really is not competition. There are another 500 or so sole community providers or rural referral centers. So inherently, it's hard to say that competition plays out in a very even way.
Competition amongst hospitals is an important issue, and we're going to get to that as a part of this series of hearings that we're going to hold. But right now I want to talk about competition between doctors working in the hospital and doctors who are working outside the hospital. How do we promote that? How do we assure that we continue to have competition from physicians who want to practice on their own, or from a societal standpoint, from an economic standpoint, it's important that they be outside the system and practice on their own?
And I think that pluralistic approach still exists, that is out there today. But I think what's important to recognize is that there are a lot of physicians that want to be in practices that are group practices, whether they are on their own or whether they're in employed arrangements. And there are a lot of physicians in the next generation that are coming out of medical school that actually want to be a part of these groups because they don't want to take calls 24/7, and they want to be part of these teams.
Mr. Chairman, if I might, I'd like to let Dr. Gottlieb answer the same question that I just did.
Without objection.
Mr. Pollack. Well, the question is, how do we assure continued competition in communities that have only one hospital system, when the fact of the matter is more and more physicians go to work in the hospital and take up that competition?
I think we don't, and I practice in one such community. I think when the hospitals monopolize most of the local physicians, it's very hard to have provider-based competition. And I do believe that provisions in the Affordable Care Act have skewed the market in this direction, quite deliberately so. I think it's part of a broader political philosophy that I think to date hasn't been successful.
Thank you, Mr. Chairman.
The chair now recognizes the ranking member of the full Judiciary Committee, Congressman Conyers from Michigan.
Thank you, Mr. Chairman. I welcome the witnesses, apologize for my late arrival, and I'd like to start off with Professor Greeny by asking him what he has heard or observed here today that you think we ought to be most cautious about in terms of this analysis between competing aspects of providers for the Affirmative Care Act.
Thank you, Mr. Chairman. I think several of the things that have been mentioned today,
Pull that mic a little closer,
several of the
sir.
things that have been brought up today, I think, are absolutely valid criticisms of the current state of the law. I think the disparate payments between site of payment really makes no sense. MedPAC has put out studies showing that those payments should be adjusted appropriately. That's the kind of change that I think Congress can step in and correct pre-existing law that pre-existed the ACA, and take steps. Chairman Conyers has been talking for many years about the McCarran-Ferguson Act. You heard Dr. McEnany's testimony about changing the fraud and abuse laws to permit and encourage greater cooperation short of mergers. There are many of those steps that can be undertaken, and I think Congress should devote its attention to those things because we have a lot of old law that's like barnacles on the hull here. There's old law that's dragging competition down, but they preceded the ACA, and Congress could and should step up to the plate and deal with them.
Thank you. I wanted to yield, if he needs time, to my friend from Georgia, Mr. Johnson.
Thank you, Mr. Chairman. I will go back to Dr. McEnany. You mentioned the narrowing of physician networks, which happens when insurance companies consolidate. Could you tell us a little bit more about that issue?
Thank you very much, Mr. Johnson, for that question. That is one of our major concerns. When a patient who has, in my field of cancer, has a specific need, say a genomics test that says a certain drug is indicated, I have to be able to go to my insurance company and convince them to provide that medication or that service or that referral. The more consolidated the industry becomes, the further away it is from my individual patient, the harder it is for me to weave through the regulatory areas of the insurance company to be able to get to somebody who can approve that drug for that patient, and it often takes months. The more burdens that...
And by the way, that's not the regulatory apparatus of the government. You're talking about the regulatory apparatus of the insurance company.
Exactly, sir.
All right, proceed.
Yes, that it gets very difficult for me to be able to advocate appropriately for my patients when the insurance company is small and local and they need me. Then in their network, then they will listen to me when I try to get something for a patient. If I go to a national network, or I'm obviously always advocating for a patient, I become a disruptive physician, and I am less inclined to be included in that network because I spend more money and I am a thorn in the side of the insurance companies who don't want to buy those expensive drugs and processes that Dr. Gottlieb was talking about. So it's very intimidating to physicians if you know in your practice that you can't do without a given payer. They know that they don't really have to pay attention to what you're requesting because you can't afford to leave.
And consolidation aggravates this
It will make it
situation.
far worse. Yes, sir.
All right, well, let me ask Professor Greeny, contrary to reports that costs have gone up overall for consumers since the passage of the Affordable Care Act, shifting of, say, premium increases to more higher deductibles and copays and that kind of thing. What is your response to that, sir?
We've seen a number of studies where competition has lowered premiums, has lowered costs. The exchanges are a particularly good example where new entry, where it has occurred, has had a very beneficial effect on costs. The individual markets experienced much better cost experiences. And I think the message here is that competition works.
Yeah, 9.4 million seniors have saved more than $15 billion on prescription drugs since the passage of the Affordable Care Act, an average of $1,598 per senior.
Yes, and
You can finish,
Thank
sir.
you.
The gentleman's time has expired, but you can finish your.
well, I was just going to mention that one important driver of cost is whether we get new entry into markets. And there's a particularly interesting example in Arkansas. When it expanded Medicaid, Arkansas said, let's have the private option. Let's have private insurers cover the new Medicaid beneficiaries. What happened there? Not only did the new beneficiaries get covered, but it increased competition in the marketplace in Arkansas. So everybody benefited, including the private market. It went from 2 competitors to 6. So private competition can be generated, and I think states that haven't expanded Medicaid are shooting themselves in the foot in the private market as well.
Chairman Marino,
Yes, sir.
could I ask unanimous consent for one question additional?
Yes, sir, without objection.
I thank you so much. My last question is to Professor Greeny again, and it's about the implementation of the health insurance exchanges under the Affirmative Care Act. Has it promoted competition in your view?
Oh, most certainly. I think we've seen a lot of markets where there's been new entry and there's been a shakeup of the markets. But there are still plenty of markets where we haven't had much competition, new entry in exchanges. And that's why Congress is rightly concerned about the insurance mergers, because we want new entry. But if we've gone from 5 down to 3, the most likely new entrants are going to disappear. So that's a concern on the horizon.
Thank you, Mr. Chairman.
Chair now recognizes a congresswoman from California, Ms. Walters.
Thank you, Mr. Chairman. I want to direct the question to Mr. Durham and then give Mr. Pollack an opportunity to respond. Mr. Durham, your testimony raises concerns about hospital consolidations. The testimony cites an analysis that claims, quote, hospitals and acquisitions increased 44% between 2010 and 2014, with a total of 442 transactions occurring during this time frame, end quote. Surely not all of these mergers have an anti-competitive effect, and how do we differentiate between a consolidation that increases competition and one that decreases competition?
A very good question, Congresswoman. I believe that is really a detailed analysis that the Department of Justice conducts. They look at data that is not publicly available and examine it at the local market. It's critical that this analysis be done in specific geographic areas to really determine the potential impact on competition. And as I mentioned in my testimony and oral statement, DOJ sees that there are circumstances where mergers can create efficiencies and enhance competition. So it really depends on what they're seeing in a local geographic market. Where health plans are, we're all about driving value, moving away from antiquated fee-for-service model that pays for volume, drive value for patients, lower cost, higher quality care. And these mergers can certainly make that happen, particularly when 2 companies have different areas of expertise. One may have expertise and have done a lot in chronic care management, while another has done more in value payment models with collaboration with providers. And bringing those 2 together can bring higher value to patients, and that's what we're focused on in terms of bending this cost curve.
Thank you. Mr. Pollack.
Thank you very much for that question. I appreciate it. Mr. Durham's testimony has a litany of studies that talk about how consolidation increases prices. I think a lot of them are old. They're old data. They're incomplete. For example, there's one study that's mentioned in the testimony that looks at 12 states, but they only say that they can find a relationship in 3 out of the 12 states. The 3 states that they look at, Ohio, Georgia, and Missouri, have a lot of critical access hospitals, rural referral centers, and sole community providers, which we said inherently are a different situation. The newest studies that we've seen from JAMA shows that, in fact, we have reduced costs. We have seen other studies that show that our price growth is at historic lows, and we have studies that I'd be glad to submit to the record that does not show a correlation between consolidation and price increases. The last and very important point is that we also did a study that I submit for the record by the Center for Health Transformation, and it looked at hospital deals, if you will, between 2007 and 2013. There were 607 in that period. That represents only 12% of our field. Of the 607 that occurred, all but 22 resulted in at least 5 hospitals still remaining after those consolidations. And of the 22 where there were less than 5, if you go through the stories of each of those 22, some were to prevent a bankrupt hospital from going out of business entirely. Many were to reconfigure hospitals so they can exist to be an access point in communities that wouldn't have access to care. So I think in the hospital world, our arrangements are focused on a different objective, which is to move to the future in terms of rationalizing the system and finding ways to preserve access where many people just wouldn't exist if we didn't have these arrangements. Thank you.
I yield back.
Thank you. The chair now recognizes the congressman from Georgia, Mr. Collins.
Thank you, Mr. Chairman. Mr. Green and Mr. Gottlieb, I have a question. I'm going to frame the question, and I'd like, Mr. Green, if you'd start, and then Mr. Gottlieb, you would weigh in on this as well. One, I want to thank the chairman for holding this in this series of hearings that we're going to be having on looking at these issues and on similar topics, but I also want to focus a little bit today on one because I want to encourage one that would be a hearing on this issue in particular, but it's the effects of PBMs on competition in the healthcare market and how Obamacare may have affected that competition in that area. This summer, the FTC approved CVS's acquisition of Omnicare without conducting a significant investigation into the combination of the largest long-term care pharmacy with the largest Part D PBM. The FTC's lack of action ties into other concerns I've heard from my constituents about the conduct of PBMs and their effect on competition. Independent community pharmacists play a vital role in Northeast Georgia, where I'm from, a rural community, and across the nation, but they're being crippled many times by burdensome regulations and also the often, at times, abusive PBM practices. My constituents and I share a concern that the way Obamacare treats the PBMs will further harm independent community pharmacists. To that end, Mr. Green and Mr. Gottlieb, I'd like to know, in your opinion, what can be done to ensure independent pharmacies and PBMs can compete on a level playing field, and this post-Obamacare environment, has really Obamacare affected that? And do you feel like, aside from congressional action in the PBM space, could the FTC be doing more and, in this area of PBMs and independent pharmacies, especially in the healthcare chain, as we'll discuss it? So, Mr. Green, I'll start with you.
Well, surely I agree, Mr. Congressman, that the PBMs are like other intermediaries in healthcare. They play an important role in containing costs and doing the bargaining. But if their size and their market structure is concentrated, we face the same problems we face in other industries. And I think particularly in PBMs, there was the controversial decision of the FTC to allow the Express Script Medco merger some years ago.
Excuse me, sir, can you pull the mic up?
There was some question about the FTC's decision to let that merger go forward. And at the time, the FTC was comforted by the fact that there would be new entry and smaller participants would generate more competition. And the FTC has done retrospectives of its own decisions. And this might be a good time for it to do so, to look back and say, how has that worked out? And to the extent that their prior prediction has proven untrue, and I don't know that it has, but I've heard talk that it has, maybe it would be time for a retrospective to see how the market is operating.
Okay. Mr. Gottlieb. Dr. Gottlieb.
Well, I'm less concerned, to be honest, about the vertical integration of PBMs trying to make acquisitions outside their core space and the horizontal acquisitions that would increase their market concentration. The reality is we have a concentrated market for PBMs, and the Express Medco merger would concern me more than the Omnicare acquisition, because it's more of a vertical integration. What's happening is the PBMs are trying to sort of buy their way out of their current market to try to capture more margin from other market segments. I think that this would all be less concerning if it was easier for new PBMs to get started and existing PBMs that are small to continue to grow by trying to offer focused services and differentiate themselves in the marketplace. Quite frankly, I think the health plan consolidation will make it harder for smaller PBMs to continue to grow, and will potentially give more market share to some of the existing large PBMs.
Well, I think one of the things right there that concerns me is look, there is a PBM market there, and we're understanding that, but my problem is concerning our independent pharmacies and others who are outside this, who provide a service in communities in the healthcare chain that are basically, because of many times the practices, small or large, are being wiped out. I wasn't going to do this, but Dr. Mack, y'all have anything to add on that, especially because I've heard from physicians as well who struggle with their patients to get drugs filled at a certain area, and because of restrictions, especially in my area of a rural area.
I would agree with you as another person from a rural area, sir. What we have found in practice is that the PBMs add another barrier because of their large consolidated structure that makes it hard for us to get patients what we want, and it has driven a lot of independent pharmacies out of business. And those were the pharmacies where when somebody needs something at midnight, you can get the pharmacist to provide the drug. When it's a large consolidated company living 1,000 miles away, they're not going to open a store to get patients something in the middle of the night.
I'm glad I'm not one of the only ones that's actually been ringing this bell. Look, this panel is great. Our time is limited. I think, Ms. Durham, I think we've had a chance to talk about this, how we deal with this and isolate. I appreciate you being here and the challenges of rural health care in a market in which consolidation is really not an aspect, because you have a dominant player and you have a lot of smaller players due to many things. Obamacare, frankly, is one of them that is very struggling right now in many markets. So, again, Chairman, great hearing. I think this is something we need to continue. Again, my focus a little bit more on that issue of drug in the whole healthcare chain, along with our hospitals, because it's been affected in them as well. With that, I yield back.
Thank you. The chair now recognizes a congressman from Texas, Mr. Radcliffe.
Thank you, Mr. Chairman. During my time in Congress already, I've had to fight to protect the 700,000 Texans that I represent from the perversely named Patient Protection and Affordable Care Act, because let me assure you, the stories that I get from my constituents certainly confirm that the law does not protect them and that it's certainly not affordable. Time permitting, I could relate to you hundreds and hundreds and hundreds of examples, like constituents of mine in Paris, Texas, a business owner who's seen his monthly costs go up $300 and his deductible go up $3,000, or another constituent in Gilmer, Texas, who's seen his deductible go up over $7,000 this year. And now the news is even worse, because we're told that the cost of insurance plans on healthcare.gov in Texas are expected to increase by another 25% next year. Does that sound affordable to anyone? I don't think so. It certainly doesn't seem that way to my constituents, because survey after survey showed that 80% of them are opposed to Obamacare and want to see me help get rid of it. And it's not just individuals, it's hospitals. The impact on hospitals in my district has been frankly gruesome. I've had hospitals in Gilmer and Linden and Mount Vernon and Clarksville close in just the last 2 years alone. How do my constituents that live in those rural areas get access to life-saving care and treatment that they need? How is this improving access to my constituents? The simple truth is that it's not, that Obamacare has reduced access, it's increased the cost of health care, and it's lowered the quality of health care in my district. So I appreciate, Mr. Chairman, you having this hearing so we can learn from these witnesses on how we can keep insurance affordable, hospitals accessible, and health care competitive under this terrible law. So let me start with you, Dr. Gottlieb. Do you believe that the heavy regulatory burden under this law is driving solo and small group practices out of the healthcare market?
Well, I absolutely do. I think the ACA provisions are biased in favor of consolidation of physicians into large systems. I think the arbitrage that we talked about today between the Medicare billing system, the inpatient and outpatient billing system, and the site of service patients is certainly one. But also, if you look at the payment reforms, they're all structured around the idea of doctors practicing in integrated delivery systems, but they're biased in favor of a hospital owning that delivery system. For example, there's a need for physical infrastructure of the IT system. The anti-stark provisions don't apply unless doctors are part of those new arrangements. And I think there's a way to try to come up with policies that give an equal footing to doctors practicing independently, but still practicing in an integrated way, but not requiring them to sell their practices. The other thing we need to keep in mind is that the law also increases medical practice costs quite substantially at the same time that physician reimbursement is being held flat under Medicare and probably declining commercially. So doctors are seeing their costs go up year over year, and they're seeing their revenue stay stagnant or decline. That's also forcing them into these arrangements.
So, Dr. Gottlieb, what impact will this have on competition?
Well, I think it's my view is, and I practice in a market that has a lot of doctors, but I believe in my market competition is declining because a handful of health systems are monopolizing the local providers. I think the bigger question before this committee is also the issue of productivity. And these arrangements, there's no good data demonstrating that productivity actually improves among providers inside these arrangements, and that medical practice itself benefits from scale. And there's a lot of studies demonstrating the opposite. I mean, I'm sure you could find one or two studies that demonstrate the counterpoint, but there's a body of literature now showing that productivity goes down, and that should worry us.
Thank you, Dr. Gottlieb. Mr. Durham, can you comment on the Obamacare's impact on access to mental health services, and what's the insurance industry doing about it?
Certainly, Congressman, I'd be happy to talk about that. Our industry has long supported the Mental Health Parity Act, and health plans have been committed to implementing parity requirements to ensure that patients have access to high-quality, evidence-based treatments and care at affordable prices. Now, there is strong enforcement of parity laws, and health plan benefit and coverage options related to mental health services must be approved by state and federal regulators. Health plans' coverage decisions for mental health and substance abuse follow evidence-based guidelines and recommendations from leading medical and behavioral health specialists, and our plans are reviewing new evidence every day to make sure patients have access to safe and effective treatments. There's still more work to be done here to address the wide variation in clinical practice and the cost of health care that pose serious barriers to patient access. We are committed to improving the value of care for all patients, particularly those that are suffering from mental problems.
Thank you, Mr. Durham. I see my time's expired. Mr. Chairman,
Thank
I'll
you.
yield back.
Seeing no other members to ask questions, this concludes today's hearing. I want to thank all the witnesses for attending and being present. You all contributed to answering questions that are important to us. And without objection, all members will have 5 legislative days to submit additional written questions for the witnesses or additional materials for the record. This hearing is adjourned.